just for the minutes, we are quorate. We will be quorate should we need to make a decision. Just a couple of things, if you could please keep your mics on mute, keep your videos on ideally. You have my permission, please, every 30 minutes or so to just turn your camera off for a few minutes, stand up, stretch your legs, do what you need to so you're not sort of sat there in front of a screen. Just make sure you keep your mic off if you're going to be shouting. And we've got apologies from Martin Hanlon, Paul Jabara and Pam Donnelly for this meeting. And just for the purposes of today, I think this is, Councillor Land, this is your first meeting, is it? Or did you come last time? Sorry.
I think this is my first.
Excellent. In which case, I will do my best to do a very quick round of introductions, if that's okay.
Thank you.
What do you want to go first?
Yeah, nothing to shout home about. Councillor Land, I'm a Essex County Councillor for Tendring Rural East, District Councillor and Parish Councillor, so all things council.
Welcome. I'll do my best to make sure I include everyone. So Ed, do you want to start?
Hi, Ed Garrett, I'm the Chief Executive of the CCG.
Jane?
Hello, Jane Paling, I'm the Director of Finance for the CCG.
Mark?
Hello, I'm Mark Corey, lay member on the board, but also a district councillor and a county councillor too.
Richard?
Richard Watson, Deputy Chief Executive of the CCG.
Vicky?
Hi, I'm Vicky Saltair. I'm the Deputy Director of Performance and Contracts, so I'm standing in for Paul Jabara, who's Director of Performance Improvement.
Patrick?
Thank you. Patrick Higgs, Director of ASC Operations at Essex County Council.
Pam?
Hi there, pleased to meet you. I'm Pam Green, Chief Operating Officer of North East Essex CCG and Exec Lead of the Health and Wellbeing Alliance.
Max?
Hi there, pleased to meet you. I'm GP, elected GP member of the board.
Frida?
Yeah, hi, welcome to the meeting. I'm Frida Barty, a GP and elected member of the board.
Firas?
Hi, I'm Firas Hussain, GP and elected member of the board.
Jerry?
Daniel knows me, we play cricket together. He bugs me repeatedly about a playground in Pork Lane. I'm Jerry Wedge, Audit Committee Chair and lay member.
Lisa?
Hello there, I'm Lisa Nobes. I'm Director of Nursing for North East Essex CCG.
And I'm not sure if Amanda said she was going to take a call. Amanda, are you there?
Yeah, I'm here. Hi, Daniel. Amanda Lyes, Director of Corporate Services.
Okay. And I'm Alison Chan. We've met. I'm GP and Chair of the board. I think that's everyone because everyone keeps moving around every time you start this. So have I missed anyone? Perfect. Right. So welcome, Councillor Land.
Thank you for that. That was far more than I ever expected. Thank you. Much appreciated.
Yeah, most welcome. Declarations of interest. So has anybody got any new declarations of interest or anything relating to anything on the agenda they wish to talk about or declare now? No. Perfect. So can I take us to the minutes? And once again, I wasn't at the last meeting and Donnelly's offered her apologies, so I can't comment on accuracy or content, but I'll pause for a second, see if everybody's content with the minutes.
Happy that they're reflection, yeah.
Thank you. Let's just go to maybe too quick for my tablet. Move to the action log. So the IPR, Richard, are you in position to update on the integrated performance report? In-depth report?
I think that's more likely Paul, but I'm happy to pick up with Paul offline.
Okay. And you were going to bring some more information around the neighbourhood plan, Pam, but I think that's in your update. You can bring us up to speed, can't you? Pam G? I'll answer for you. Yes, you can. And Amanda, large concerns with winter pressures agreed that new risks at winter, which you've done, I believe.
Yeah, that's on the board assurance framework. Thank you.
Sorry, it's raining here. We've got that item on the agenda, so
Yeah.
health updates later on.
Perfect. Excellent. If we can close them all, in which case let's move on to Chief Exec report. Ed.
Thank you. So three issues I wanted to update on. Firstly, around the recovery of elective waiting lists in our hospitals. Our ICS was one of 10 systems nationally to be designated as an accelerator site. So we were asked to go quicker in terms of recovering waiting lists than others to share best practice and set a good example. I'm pleased to say that we're the only system nationally to have met our commitments by the end of July, which is a really fantastic achievement. The average waiting time is reduced from 53 weeks to 43 weeks across the ICS. But looking at Colchester Hospital separately, it's down to 40 weeks. So we're making very good progress locally as well as across the system, but still a long way to go. In terms of people waiting over a year across our ICS, we've reduced the number from 7,336 to 3,825. So making good progress on the long waiters. And as part of the work, we've now got up and going our community diagnostic hub at Clacton Hospital, where we've secured £9 million worth of investment, and all of the diagnostic services will be fully up and going by April 2022. And that's one of 40 new diagnostic sites nationally. On vaccination, we're moving into a new phase, and thank you to everyone on the call that's involved with the vaccination programme. We've given a jab to 73% of our 16 to 17-year-olds in North East Essex, against a national average of 53%. So making strong progress there. In terms of COVID boosters for cohorts 1 to 9, so this is the over 50s and people with underlying health conditions and health and social care workers, we've given a booster to 34% of the cohorts that have been opened. So again, a lot of hard work there. And then we're also vaccinating our 12 to 15-year-olds, and that's being done through Hertfordshire Community Trust, who have been commissioned by NHS England to do so in our schools. So a lot of work on vaccination, and very grateful for everyone's efforts, and we're keeping up a very strong pace as we've done all the way through. And then finally, I just wanted to express a message of support for the GP community in North East Essex. I think GPs everywhere up and down the country are facing huge surges in demand, up to twice their normal workloads. But unfortunately, there have been many examples of abusive behaviour from the public towards the GPs, and a lot of frustration. But I just wanted to emphasise how hard everyone's working to see everyone and to provide care, and just to express my support and gratitude to everyone within North East Essex CCG GP community. Thank you, Chair.
Thank you, Ed, and thank you for the recognition of the hard work, but not just us GPs, but you know, we're all doing out in the community at the moment. It's a hard slog. Must have never been sworn at as many times in the last couple of weeks as I have probably in the last 5 years, which always a bit shocking when it happens. Any questions for Ed or around any of the content? Mark.
Thank you, Hassan. I think that last point from Ed and then added to by you is concerning. I know that it has been really difficult, and sometimes even from my local experience, communication between surgeries and the community isn't always the best. But it's absolutely unacceptable for GPs who have been there for our communities for a very long time, and even junior doctors coming in. Anyone does not deserve that treatment. And I would like to think how we as a board could, not only through the thanks that Ed has given, and I'd completely add to the GPs and others working in the community primary care areas, but how can we work to ensure the public do not abuse our hardworking staff who are there for their own well-being, for these as patients, for the well-being of them. So how can we stop that happening? How can we improve upon it? That's something we could take away, please.
Thank you, Mark. I'm just going to bring Max in. Max.
Thank you, Chair, and thank you, Ed, for your comments. That's very much appreciated. Can I just ask about the diagnostic hub? For when do we think that will come online? How soon? Because it's obviously big, well needed, particularly in terms of trying to get to grips with some of these cancer targets that we've got.
Yes, so some of the services are already up and going, and I can send you a note, Max, with all of it. But the site will be fully mobilised by April 2022, is I think the plan that we're working to. So I think a lot of rapid work. It's really great news. I was asked by the MP last night about the volume of patients that will be seen through the hub, and I'm going to get that answer to him, and I'll share that with you too. But I think this is fantastic news for Clacton and indeed tendering, and exactly what we should be doing, providing more elective services.
I talked to a lot of patients in tendering and, Walton and Frinton area, and they really do not like going to Colchester for their investigations, and I think would to be able to say to them, look, you can have this investigation in Clacton is going to be very much appreciated by a lot of the population in that area.
Thanks, Max. And just in response to your question, Mark, so we did send a letter from the three chairs actually to all and Ed to primary care as a letter of support. And there has been lots of, and I think a few months prior to that, the CCG sent out some modified posters to be put up. And I have to say, I never thought I'd be in a position where I have to put up a poster in the surgery saying, your abuse is not welcome. But sadly, I think we've got to that point now where we have to. And one understands patients' concerns and anxieties, and you need to balance that out, of course. But it's knowing that people have been threatened and physically abused up in the north of the country as well. I think we just need to be mindful that tempers can quickly accelerate, especially when health is concerned. Lisa.
I'd like to say it's something that's also being felt by other providers that we have as well. Certainly the ambulance service had 47 physical assaults across their services in 1 month, which is a significant increase, and the verbal assault also increased, but 47 physical assaults.
I'll say thank you, but it's not really. Don't really want to thank you for saying that, Lisa. But yeah, no. As I said aside, it's all providers, isn't it? There's everybody out there delivering a service. Down to, I'm sure, shopkeepers are probably getting a lot of flack at the moment as well. Not least to say petrol garages. Frida, you're on mute, Frida.
Adding on to what Lisa said, really, that now we are actually considering the safety of our female GPs on visits, which I think is a really frightening place to be now, especially in parts of tendering. And I think that's really a reflection of how sad, how much we feel we have to protect our female GPs now. Just to make that point on from what Lisa said as well about the paramedics.
It is very sad, actually, to be fair. But obviously, we've been had to for a while, haven't we, ensure safety of all our people when they do housebound, male or female. But it's concerning when you have to start thinking about it. It's just a worry, and I just maybe we do need to take some time to just think about how best we support everyone, whether it's comms or whether it's training, maybe even something as simple as, forgive me, self-defense training. Maybe there's something like that we need to start thinking about as well. But hopefully it'll never be needed. But unless there's any other questions about the exec update, that's the most useful, well, the most conversation we've had about your update since a long time, actually, Ed, isn't it? So
It's a backhanded compliment.
Yeah. It's amazing what happens when you say something interesting. Councillor Land.
Oh, Dan, please. Can I just ask what the sort of bane of the frustration is coming from? Is it because people have been delayed in their provision of services, or is it a mixture of things?
So I don't think there's a quick answer to that. I think it's different in every different case, but I think all it comes down to is just a frustration that actually what they expect to receive isn't what they are receiving. And sometimes that's realistic, sometimes it's unrealistic. But I think the issue is not to attack people who have concerns around service delivery. It's just really the approach, and it's the attitude towards raising challenge. I think no one's questioning the ability to raise challenge. You should do, and you have the right to. It's just how you do it. Without getting physically or verbally aggressive. I think that's the point we're making, not the reason for them posing a challenge. Frida.
Can I just really add very, very quickly? It's also the media. Recently, it's bad press against GPs, and in some ways backed by the certain aspects of the government as well in House of Parliament. In the Parliament's question time thing, hasn't been helpful.
Okay, thanks, Frida. So just moving on, I'm just clocked now that Myrna hasn't joined us, and I think she still hasn't. So I'm going to take the HFC report as read. If anyone's got any questions or comments around specific content, can you direct it to Myrna and perhaps copy either myself or Pam in so that we're aware? That's okay. If she joins later on, then we'll come back to it. Unless anybody's got any questions I wanted to raise now. Okay. Oh, Ed, sorry.
Well, I mean this in the nicest possible way, but there is no real content in the report, and we've had this standard report for a few months now, so I'm just concerned that we're not capturing the work that's going on.
So does Mark, do you still attend HFC meetings for us? Have they had a meeting?
Short answer from me is no, and whether I've missed virtual invites or not, I don't know, but they haven't invited me to a physical one any time in the recent past. But I'd be happy to engage. I do think we're missing out with COVID. We've lost some people in a sad sense, but also just due to other factors. So we do need to have a bit more work on this, I think, especially with the changes in terms of ICS footprints and
we often place a lot of emphasis on the HFC and that opinion feeding in, but if it's not working, then I think we need to think about how we do it better. I completely agree. Maybe that's I haven't been to HFC myself for a while, since COVID actually. Frida?
Just very quickly, also this reflects upon the PPGs largely being not very functional at the moment. I think across areas, certainly in tendering, because of COVID and because a lot of the people that go to PPG were coming face to face into village halls, and going onto internet like Teams or Zoom didn't necessarily suit the way they communicated, and so we're finding our PPG is really not functioning either, which is a problem because we used to get quite a lot of good feedback from the PPGs, and that reflects into the HFC as well. So I think it is a post-COVID thing. We need to re-establish that kind of link again with our PPGs out in the community.
Okay. I agree. But perhaps we can pass that on to Myrna, Ed, as a comment. Maybe she'll join later so we can say it to her directly anyway, actually. So let's move on to item 8. That's the Neighbourhood Programme Alliance update. Pam?
Yeah, thank you very much. I'm not sure if sharing the screen is going to work particularly well in this setting, but I'm quite happy to talk you through the slide deck and take any questions. So I wanted to shine a spotlight on the piece of work that we're doing around our neighbourhood teams. So this is an update to demonstrate how the North East Essex Alliance is now coming into delivery and full operational mode. So for those that aren't aware, Central Colchester is the first place that we will be pulling together health, social care, district, borough, voluntary sector and community leaders together in a virtual and integrated team. to support the needs of our population, embodying the full strategy of the Alliance, which is not just looking at the medicalised model, which again, when we come back to the conversation of some of the frustrations that we're seeing in primary care from our citizens, some of those are not indeed to do with medical origins. Some of them are to do with frustrations over housing, frustrations over concerns around benefits, and all sorts of other things that either perpetuate physical health or cause issues in people's day-to-day lives. So bringing the team together so that we can support our citizens in a fully joined up way is the principle of the neighbourhood team. It goes further than most of the evidence that we can find across Europe and across this country of joining up teams. So it's more expansive. It's more about the place than it is just about health and social care. So you will see within the papers that we've done a full literature review of the models that are out there, and we've taken pieces of learning from all of them to enable us to move forward into the engagement phase of setting up these teams. They really will be taking on common purpose, and that's to support citizens and their medical and psychosocial support, and to ensure that we get the best value possible out of the funds that we have to spend within the North East Essex setting. It's a huge piece of work. It's a huge journey around engagement and bringing forward all of those voices, particularly in Colchester, around the families. And if we look at our population health studies, it's very clear that there's needs around the young people within central Colchester, that we need to look at the services and the way that we join up services together. So it's a summary of the excellent work that's being done across parties. So not just health, as I've said, incredibly strong leadership from Colchester Borough Council and their teams, their safety officers, their wardens, etc., coming into this space, and the evolving design of that team and how it will function. Obviously, there's practical things that we're working through in bringing this team together around estate utilisation, information governance, how we interact with the primary care network, so the collections of GPs. But it's got high aspiration, and it really does fit as one of the main pillars of working to deliver the Alliance long-term plan. Wherever possible, a preventative ethos and an asset-based community developed ethos will be taken on by the team. So ensuring that we have a community, voluntary sector and a good understanding of the assets within our communities is one of the key elements of making sure that this is a success. Go live for this team will be at the beginning of December. So there's a lot of work to do from now till then. But I'm very happy to take any questions from the board about this piece of work.
Thanks, Pam. I was going to suggest if anything, you could put up the programme governance slide and just explain that to everyone. But I don't know how easy that's going to be. But could you just talk through the governance around how we're going to make sure there's inclusivity of programme design across, say, primary care, community, council, health and social care, anyone and everyone? You're on mute.
I will try and share it, but whenever I try and share my desktop, it crashes my system at the moment.
Oh, well, no, then it's just really I was looking. I mean, firstly, it's a great slide deck, and I think it's really easy to follow. But I just thought, at board one might just ask the questions about the governance bit about it and how effective it is and how we're testing that that's the right model.
Yeah, so that's the process of full engagement with all of the teams. So we've got an operational working group that are developing that the way of working together. So this isn't a enforced way of working. This is being developed from the teams upwards. That operational group then report into the strategic group that then reports into the Alliance Committee. So the governance from that perspective, that's how it goes through the Alliance, but obviously that any decisions around form of those teams, and Patrick's here from Essex County Council, so he's taken through his governance around setting up the response for social workers working in a different way, working with our voluntary sector and hubs. So it does require sovereign decision, as well as obviously this board to make decision, but that's coming and being driven from the operational group up to the strategic group and then out to the sovereign organisations. So that's how we manage it through that process. We obviously haven't got a body that can make one decision across all of the sovereign organisations at the moment.
Okay, thanks. And just one quick thing, I can't remember if it was Mark or John Price that mentioned it, because with the growth of the alliances and there's a lot more terms that are coming into place, so we just need to make sure if there are certain terms in papers like LNT, sorry, I probably should know what it means, but just we think about that in terms of our abbreviations and index for future.
Yeah.
What is LNT, by the way?
Local neighbourhood team.
Oh, of course. Matt.
Thank you, Chair. Thank you, Pam. Can I just, so in this sort of neighbourhood teamwork, are we focusing on how to develop communities? And I think actually it's a good choice to go with Central Colchester as the first of the neighbourhood teams, because it's probably almost, with all the population growth, and that we've had in Colchester, it's probably the most challenging in terms of actually developing a community. I was interested to hear that you're sort of looking at evidence across the world on this, and I just wonder whether we've looked at how you develop good communities, because that for me would be the key to the success of this project, and is often neglected in planning, in terms of planning,
If Leanne Jean-Pierre was here now to talk to it, you'd have just given her a window to talk for about 40 minutes on the strength of communities. And that is one of the principal pillars behind this, actually. It's compassionate communities. It's building on the strengths in our communities. That's why we're taking an asset-based community development approach. So one of the key pieces of work that we're looking at across here is the connectivity, and we're going to be doing a piece of evaluation, because actually, how do we prove we've been successful in this piece of work? It's not just about, do we reduce the referrals to GPs, or do we reduce the referrals to hospitals? Actually, it's have we supported a community becoming stronger? Have we enabled people to feel more connected to their communities? Are they happier? So actually the design piece of work that we've just done to evaluate our neighbourhood teams is really testing sort of our evaluation skills, and we're actually going to be bringing in another partner to support us on that, because this is a longitudinal study of have we done what we essentially said on the tin to make lives better from cradle to grave, because obviously our live well strategy is about starting well and dying well and everything in between. So we're looking at, the Alliance has invested for the last 3 years in piece of work around assets. So the asset mapping is a critical part of this, but not just the asset mapping, but how connected are people to those assets within their community, and how excluded are parts of our community. So gathering all those intelligence, having this constant feed from our community leaders, and making sure that we have locality level leadership that is reflective of that community, so that we can listen and redesign as we go. Is a really exciting way of doing things. It's the first time I think I've felt really connected down to community level in all of the work that I've ever done in health, apart from when I was walking around communities delivering physiotherapy, and I only got to see a small section of the community. But in this way, you get to see a window on the whole of the community. And the teams will be very sensitive to that. So that because the teams will be working shoulder to shoulder with borough council colleagues, the housing issues around hoarding or safety or rent arrears will be able to be solved within the team, as opposed to there being a referral into another central point of access, which actually doesn't deliver a response quickly enough. We know enough about the wider determinants of health and the fact that people are not made unwell by when they're born. In most cases, it's the conditions that they live within and the opportunities that they're given. So actually working to this is our prevention model, and our whole system prevention model doesn't take away the need for us to treat people that have acquired ill health. We have to run both streams, but it is absolutely our prevention methodology to ensure that people are healthier for the future.
Thanks, Pam. Ed?
Yeah, thank you, Pam. It's really, really great work. I don't want to kind of run before we can walk, but is there a view about delegating budgets to local teams in terms of that micro commissioning? They might, as you said, there might be a problem with hoarding, so they could commission an agency to help with declutter a house. That sort of commissioning, is there a view whether we do that?
So thank you for the opportunity. We have within the slides referenced hyperlocal funding, and each neighbourhood team, irrespective of whether they're set up already or not, the locality with the community leaders, our GPs and our elected local authority councillors will be able to make decisions on ranging, because we've created the small funds based on population density, so with a range from 30,000 to 50,000 depending on the size of the locality, to be able to spend on those small interventions that would make a real difference to the population and their health. So the decisions around that's currently out in several parts of Colchester, and it's just being organised across tendering. So some of the things that have come forward for that is first aid training for families, and small bursary funds for smaller charities to support families, etc. But the panel decisions are underway at the moment to ensure that it's not just us making the decisions on that. What really would make a difference is coming from the community. So that's out there at the moment, and that's for this financial year.
Okay. Thanks, Pam. Frida.
Yeah, I just want to say that I was reading some stuff from the King's Fund over the weekend, which was published just recently in September, I think, about integrated care services and the whole restructuring, collaboration, and in neighbourhood and place and all of that. And I have to say that I have to congratulate Pam. We were miles ahead of this, and I was reading and thinking, we've done this. We've done this, and I think Pam and her team have been one step ahead of what was in that paper, and I think it's great. Well done. I think it really is.
Thank you, and I would say that we've had great leadership from our districts and boroughs and our voluntary sector that have truly influenced the strategy that we have taken here with the Alliance. We could not have got as far as we have without those place leaders coming with us on this journey and truly influencing where the barriers to health are. So we know that life expectancy the gap is widening, particularly in tendering, and we have a gap of 13 years between the wealthiest and the most deprived population. So actually we have to do something completely different to turn that gauge around. And I do think now that this is the strategy we've all got to get behind, because we know that environments make people unwell and the conditions that they're expected to live in, and that drives up demand and is almost impossible for you as GPs to solve on your own. So that's where we've seen great success with our social prescribing that's been held within our voluntary sector, because they have and the voluntary sector, you know, Ed and I are regularly re-quoting them in whenever we talk about these sorts of scenarios. But actually, the voluntary sector holds the knowledge, and it's like a black taxi cab driver. Actually, you need to know the knowledge to be able to connect people to their community. It's absolutely impossible to ask somebody to be a social prescriber without that network of support in their community to make a difference. We've seen real benefits now of our social prescribers being held as an employee of our voluntary sector and being able to support the GPs as well as our citizens. So I think that is probably the jewel in our crown in getting as far as we've got the voluntary sector and district and borough support.
Right, can I just come in on that very quickly?
Sure.
I just wanted to say that I'm amazed by the voluntary sector in terms of their contribution to the vaccine programme. Absolutely. I have never come across the voluntary sector as much. I mean, I have, but no, I mean, honestly, credit to them. We could not have delivered the vaccine up in Harwich without them, and to credit to all the voluntary sector. And I would also like to ask if anyone knows how the alliances are working in the other two regions or the other two CCGs, just out of interest, really.
So I work very closely with Maddie and Kate across the ICS. We're a peer group. We're battling with the same things and succeeding in the same areas, I would say. I think there's a social movement across our ICS for the place to be empowered. And I think we've perhaps gone a little bit further in governance terms, and that's thanks to this board having the vision to say, set up the Alliance Committee and arrange the governance. And I'm very hopeful that that governance will and type of delegation to place will remain as we transition into the ICS board and partnership. So yeah, they're doing very, very similar work. The integrated teams in Ipswich and East and West, and Richard, I'm sure, can make comment on these, have been set up for a little while, but with a slightly narrower scope to what we're trying to achieve in North East Essex. So there are comparisons made, but we're taking the learning from them, certainly around the multidisciplinary team approach for health and social care, and adding on to that the wider determinants of health piece around districts, boroughs and voluntary sector community leader support.
Can I just come in very, very quickly? Very quickly.
No, you can't. Hang on.
Sorry.
Can I just finish that off? Actually, did you want to add anything about the?
No, I think Pam's right. It's fortunate to be included in all three, and there's clear synergies between the approach that all three are taking, and each one is its own unique force of nature, and that's not just the three Qs. And I think there's clear learning from each. Yes, arguably, I would say there has been more progress, but it's been since 2014. And so in terms of some of the integrated neighbourhood team specific pieces, but as Pam said, equally in North East, there's definitely a bigger role with the VCSE sector and the districts as part of that arrangement. So they're all going in the right direction, though. And if I compare to where we are to other areas, we are, as you said, Frida, my sense is that we are quite far ahead in terms of our thinking, absolutely executing it into reality.
Okay, thanks. You can have the last say then, Frida, before we move on.
Thank you, Hassan. I just want to make everyone aware that we need to keep thinking inclusivity and diversity on all these alliance committees, please, just to represent our communities, because I think we forget that, and I think it's really important just to keep reminding ourselves about EDI.
I think it's a really important point, Frida, and what COVID has shown us is that there's a huge amount of wealth of knowledge, if only to tell us where we're going wrong very often, where we can learn. And we've fostered great relationships with community leaders, particularly through the vaccination programme. It would be a falsehood for us not to ensure that those voices continue to be as loudly heard in everything that we do going forward. It made such a difference in being able to reach our most at-risk groups.
Okay, thank you, Pam, and thank you again for all the work that you put in. And so we're asked to note that report, which we have done, and we'll move on to the mental health transformation programme update. Richard?
Thanks, Hassan. So hopefully I'm not slurring at this point, as I've just had dental treatment. So bear with me if I am doing. I am absolutely fine. So with that in mind, you've got hopefully a comprehensive update in relation to the adult mental health programme that we've got underway in North East Essex. I'll take you through, that's all right, Hassan, just some of the highlights of that, but just a couple of things strategically before I do that. So we are in the process of looking across Essex at the current adult mental health strategy that expires at the end of this calendar year. And it is likely that we are going to be looking to refresh that on a pan-Essex basis, but clearly taking account of the continuing change in and complexity in systems, as we've just talked, Frida, around alliance level, so place level, and across ICS and across county. So we'll be commencing that work hopefully relatively soon, just thinking through how we approach that. And the second strategic development overarching is some guidance that's come out from NHS England in August, which asks for all mental health trusts and indeed physical acute trusts to be part of what they're calling a collaborative, a formal collaborative. So again, there is some thinking started. What would that mean for mental health, and what would it mean for EPUT as our major provider in terms of a collaborative? Who collaborating with, on what geography? How would it relate to place-based? So more thinking to do on that one, but I just thought it would be useful to give the context of those two conversations that are underway, both at place and across Essex at the moment. So turning to the paper itself, it's hopefully fairly self-explanatory in that it splits the programme down into 4 different areas. So community mental health, crisis specialist, and as it's talked about there, other, but a lot of the voluntary care stuff that we're doing. This correlates with the national programme. So as many of you know, there's a very strong emphasis from the national team in terms of what the programmes need to include. So a lot of what I'm going to go through is actually driven by the national must-dos, but actually with our own spin on how we're actually approaching it within the auspices of our alliance work. So in terms of community, there's a number of developments under this banner, of which the board has actually been through on different occasions, including signing off different business cases and procurement. So starting with IAPT at section 2.3, as the board will know, we've commissioned a new enhanced service offering now from EPUT that has commenced, and we put in nearly £900,000 of extra investment as a board in getting to that national access standard of 30%. So 30% is where we're aspiring to during the lifetime of that contract, currently around 25%. So that's a new in Essex model provided by EPUT, building on the work that we had through Hearts Parts previously. I think the biggest new development on community is actually, and I think absolutely exciting, is the actual integration around place of mental, physical and social care. So again, links back to the conversation Frida and Pam and I were just having a moment ago. So actually, what's the opportunity now to build at that locality level within North East Essex, those integrated teams? And one of the key developments of part of that is the additional 30 mental health practitioners that we've committed to, partly through the funding that's gone into primary care, the additional roles reimbursement scheme, and then topped up through our own CCG funding. And I'm really pleased that there's been brilliant recruitment to those roles in North East Essex, to the envy of the rest of the ICS and indeed the region. And that must say something, I think, about North East Essex as a place, a destination, in terms of being able to attract additional workforce into those key roles. But those roles are absolutely going to be bound around our primary care network, supporting primary care, interfacing and working hand in glove with our secondary services around EPUT. And there's a working group in place involving a range of people in terms of how we might take that forward, and important, as I said, integrate it into that wider locality working. At the other end of the spectrum is our serious mental illness support. So those individuals who've got an SMI, as it's called. And as many as you'll know at the board, there's a national expectation that 60% of those with an SMI on GP caseloads have had an annual health check. All areas of the country are struggling against this, particularly in the last year and a half during COVID. Unfortunately for North East Essex, we are currently tracking at about 20%. But there is a clear recovery plan that we've now got into place with our support provider, GP Primary Choice, GPPC. I always put too many P's in that. And Pam and I and teams are working with GPPC and EPUT to ensure that we've got a clear trajectory to how we can try and get towards that 60%. I'm not going to say today, hand on heart, that we're going to achieve 60% by March, because I think that's a huge undertaking. But I'm really clear that there is an ambition and an appetite to do as much as we can as a set of partners to try and achieve it for this important cohort of our local population. Just quickly on early intervention in psychosis, we looked at this as a board a couple of years ago, but just to give you the confidence that the service has continued to grow in terms of its workforce and its development, and we're in a really positive position, unlike many areas of the region, where we are achieving the national standards around the 2-week access for those who've got early intervention, who've got psychosis through that service model. We're doing some further work with the current provider ePut around the at-risk mental state service, which is a national ambition as well. More recently, we've also agreed a £250,000 investment in further development of personality disorder services. So working with ePut and the clinical leads within that part of the service, we've now got more of a community-based projected model, particularly focusing on training, supervision, peer support and engagement. I think that's a welcome investment within this part of the ICS for that service. And then just to finish on community, we've also got an award-winning IPS service, which is individual placement and support service. So effectively every area of the country needs to have in place, rightly, employment support for those who've got serious mental illness to try and get those who can back into the workplace. And I think we're really fortunate with our provider in Essex to have a long-standing partner who, as I say, is actually seen as one of the best in the country. And we've continued with them. I think we've got another 3 years or so to run with that contract. Turning quickly to crisis. So this is the second arm of the programme. Again, this is quite prescribed nationally in terms of the ambition. And I think North East Essex has been fortunate to be ahead of the curve nationally in terms of the investments we've put into crisis services, although there's a lot more to do, as we know, particularly being exacerbated in the children's area that we've talked about before. But the good news is that we've put in previously an extra, obviously it's a core number, 900,000 into this one as well, in terms of adult crisis and home treatment teams. So we have got 24/7, 365 days a year, our crisis model, which starts with that 111 Press 2 model that ePut work with our 111 provider Practice Plus. And then there is that infrastructure behind to take the calls, and then a range of options to how they can be supported, including those crisis home resolution teams that are based around North East Essex. But secondly, importantly, which links into an item further down, the crisis alternatives. So the brilliant work that we're doing with our voluntary care and social enterprise sector in the Clacton and Colchester hubs that we've got, the crisis safe havens, which again, I think are at the envy of the rest of the ICS. We don't yet have those within the Suffolk patch, and they've been long standing in North East Essex and have continued to develop and grow. And then just to finish on crisis, we also have the long standing mental health liaison services in place at Colchester Hospital that we expanded again, I think, a couple of years ago. Finishing off nearly with specialists. So we've got perinatal, eating disorders and out of area placements. In all three of those areas, we put additional investment. Again, the board have had business cases previously in terms of the investments we put in. Perinatal, we are, I think, the only area in the region that has actually hit the national access standard. So to make sure that we're getting towards 10% access for those who need that kind of support. And indeed, we're actually expanding it to look at the partners of those who give birth around the mental health support that they may need through this. And eating disorders, I think it's fair to say this is on the adult side. We've got more work to do, and there's a review happening at the moment to look at the current adult eating disorders model and what we may need to do additional. Out of area placements continues to be a challenge, but in North East Essex, we've got 4 currently out of area. There was an expectation nationally that there would be no out of area placements by the end of September. I think 3 of the 6 areas in the region, including ourselves, have not hit that. So there's some more work to do on agreeing a revised timescale to achieve that. But as I say, we've currently got 4 which we've got plans for. And Lisa, I'm looking at Lisa's body language. I think that's right. That's what the information I've been given this morning. Finally, on the important work we're doing with the voluntary care and social enterprise sector, some of this is long-standing that the board will know. So the Refugee Action Colchester work that we committed to has continued to go from strength to strength. So we're in a 3-year partnership around that work. And I think that's something that we're going to continue to try and grow and develop. We've also working with Age Concern with £300,000 we've put in this financial year to as part of the community mental health offer to support particularly clients who need advice and support navigating through the systems that we've got linked to our community mental health offer. And then finally, but by no means least, the Tendring Mental Health Hub under the Citizens Advice Bureau based in Clacton, again, that we've committed to and have got more work happening. So that's quite a fast canter through what is quite a wide-ranging adult mental health programme. Should have said earlier, we have got a North East Essex Mental Health Board that meets every 8 weeks. So that board has got the oversight of the wider programme. And we do have a monthly highlight report that sets out progress against each of those pieces of work that we'd be happy to share with the board if that's useful.
Well, thanks for that detailed description, Richard. It's clear to see that there's a lot of work going on. Just before we come to questions, I didn't know whether, Firas, do you go to the board? I didn't know whether you wanted to add any comments from your perspective.
Yes, I do attend the board. I didn't have anything further to add though, apart from what's been said already.
Okay, all right. Thank you. So who was first? I think Mark, you're first.
Thank you, Hassan, and thank you, Richard, for that marvellous canter through. I appreciate the last point you said about the board and the oversight. I think that would be really useful if you could cascade that down to us. We were having a conversation earlier about funding and how that all fits together and how we must focus on mental health, and to give us the context of everything you're doing is really helpful. As chair of the Alliance Committee, I've been lucky enough to see a lot of that investment you've talked about. So I wanted to thank you again for that hard work, the investment in IAT, perinatal, personality disorders, and much more that you've run through today. It's excellent work, and it's so good to hear all those examples so well summarised. The 2 points I would make, bearing in mind my different hats and what I'm involved with, I'd not heard of Summit before, and just wondered what more we could do to hear about that organisation that helped with the enduring mental health and getting people into work, if that was correct, if that's what they were called. Have much really encouraged with that, but would like to hear more about that and see how we can communicate that further, their work. And secondly, you said that we had crisis safe havens, which are at the envy of other places. However, we still have those high suicide numbers, sadly, in both Tendring and Colchester. So how are we going to meet those two things? If we've got good safe havens, what more can we do to, I know there's pieces of work going on that you're involved with and other partners are, but anything you could comment on that would be helpful. Thank you.
Yeah, happy to. So firstly, thank you, Mark. There is also, I should have added, a quarterly, it's a fun piece, a quarterly audit that we have to account for every single pound spent with NHS England on mental health. It's probably the most regulated part of the programmes that we've got. So again, I'm happy to share, and Jane's nodding, that audit that we do. I think we're doing it the first time this week or next. So happy to share that, but we do have a lot of granular detail on the way that we're spending the mental health investment standard. Happy to provide more detail on our IPS service. I think about a year ago they came to Mental Health Board to talk about it, and indeed they are now the provider into the Suffolk system. So that's an interesting one where we've now got one provider, Pan ICS. So if the board's interested, I'm happy to provide some further detail. I'll speak to you separately, Mark, on linking you with that service provider. Suicide prevention, so absolutely, and we've had conversations with the Alliance Committee and the Alliance Board, and indeed we talked about this at the ICS Board only last month. There is some bespoke work happening within North East Essex rightly through the Tendring and Colchester task and finish groups. The decision's been made to potentially bring those together, so we've got one focus, and Pam Donnelly, who I'm just not here today, is the board champion as part of North East Essex Alliance for that piece of work. I would say, yes, there is obviously a link between our crisis safe havens, but it's only one part of the answer. We know that if we're really going to tackle some of the root causes of suicide and achieve our ICS ambition of zero suicides, it needs a whole system approach. It's very much about some of the wider determinants around this. It's not actually just those individuals who actually are known to mental health. Actually, arguably, the majority aren't known to mental health services themselves. So there's some focus work happening in North East Essex, but actually I took an action from the ICS to regroup across the ICS itself to say, if we are going to continue to aspire to zero suicides, do we need to look at what our approach currently is and how that might change or evolve to meet that? I don't have an easy set of answers, as I think you expect, Mark, but it definitely needs a whole system effort around that, which I know this alliance is committed to.
Thank you, Richard.
Thank you. Lisa, next.
Thank you. I was just going to say, I think probably next time we need to make sure that we capture all the learning disability and autism transformation work that's going on. It's really important that LD and autism isn't seen as a subsection of mental health, because obviously it's not just about mental health for people with learning disability and autism. And there's a huge amount of transformation work you'll be aware with the STOMP and the STAMP programs, the building the right support at the right time, and a lot of work that we're doing through the NHS long-term plan, through both our Transforming Care programmes and the work that Phil Brown's doing in Essex County Council. So it would be great. I'll make sure that I'll work with Richard to make sure that that's fully represented next time. Thank you.
So just to be fair to yourself, Lisa, this ask was from the board specifically on adult mental health, which is why the paper's on adult mental health. So absolutely, as you're the lead for it, there's a separate but linked programme around learning disabilities and autism. So if the board would like a focus on that, then we could bring something back.
Thank you both. I think that'd be great, but I'm biased. Ed?
Thank you. I mean, firstly, congratulations to the authors on a really, really excellent paper. I mean, the amount of detail, the way it's expressed really kind of concisely, I thought was great and a really helpful briefing. My question is probably a stupid question for you and Pam. So great news about the additional roles, mental health roles for the PCNs, which we're charging ahead in North East Essex. We're really pleased about that. How does those teams fit together with the local neighbourhood team in Colchester? Are we bringing it all together into one, or are they kind of planets circling each other?
I think we're going to say the same. No, they're one and the same. That's the point I was making earlier, is the ambition and is what is actually happening on the ground is actually now the integration of those teams. That's why I said I think it's exciting. The exciting end of the programme is actually the community mental health piece, arguably, because at long last, I think the national team is starting to focus on the fact that it can't just be mental health in isolation. It needs to be mental health wrapped around primary care with our social care and our other partners. But Pam, as you're driving our locality work there.
So what I didn't say about the map that was included in the slide deck for the local neighbourhood teams is that they don't quite overlay the PCNs, but there is about 85% congruence between a PCN and a locality team. So at the heart of these teams is our GP practices and the workforce within the GP practices, and supporting all of the staff to feel part of that team as well. So they're absolutely hand in glove. And, we have great leadership from our mental health trust in our locality teams piece of work. So actually Emma Strivens, who's the local director for adult mental health, is one of the co-leads with Leanne Jean-Pierre from my team. So that always keeps our mental health focus really close. And, yes, there's work to be done ensuring that all PCNs feel engaged, but they're very engaged at the moment in Central Colchester.
Thanks, Pam. Thanks, Richard. Patrick, first.
Thanks, Hassan. Yeah, just two things for me, Richard. One is back to Lisa's point about how we make sure we're linking up against client groups, I guess you want to call them that, around both people with learning disability, physical, sensory impairment, and older adults around the whole mental health agenda. And then the other bit is around getting people back into employment is good, but where's the links into housing with both boroughs and districts, but then thinking of wider for Essex as well.
So the Mental Health Board for North East Essex includes Moira, obviously, as you know, one of your colleagues is the lead, and another couple of, well, you're on it as well, sorry, Patrick. So the Mental Health Board for North East Essex is where we should be bringing those agendas together. I think from memory, we were looking at that housing interface, but the last one or coming up at the next one. And indeed, Moira was talking, no, it was the last one, talking about the housing review itself and work underway. So we definitely need to bring those agendas more together. And also on a pan-Essex basis, we also have a mental health commissioners meeting on a monthly basis that brings together the NHS and local authority commissioning leads. And again, that's been something that we've been looking at. The wider correlation links between all those various bits, I think there's an opportunity with the strategy work that I started with to have a proper think about how we bring those agendas together. But happy if offline, Patrick, there's more detail on where you think we might be able to do more, happy to pick that up.
If I can just come back, Richard, I think there's a real opportunity through the new ICS model and making sure that we get that embedded into how we start to develop the strategies for all the 3 ICSs that cover Essex about getting things more local and thinking about how we bring out into that space beyond health and care and do some of that wider determinants of health, particularly around housing and employment. I think we can use that as a vehicle as well. That's
absolutely the direction. Just to say, we haven't so far, and I'm definitely not looking to have one mental health strategy for the ICS. There will be a Suffolk-based one, and there will be a North East Essex aligning into Essex one. There is no, in my view, it doesn't make sense to try and aggregate it personally because of the different complexities, different systems, different partners, although there is complementary areas like the IPS where it does make sense to look across.
Thank you, Richard. Frida.
Yeah, very quickly, just going slightly back to Pam's point about EPUT and leadership in EPUT and the PCN and locality place. Basically, in the neighbourhoods. Basically, Emma Strivens is excellent as a leader there, without any doubt at all. She's really easy to get hold of, really easy to talk to. There is a slight issue, I'm not sure Richard's aware of, in terms of the technology and incorporating the licenses between EPUT and EMIS and System 1, which is holding us back a little bit on this. And I think we really need to push on that because there's agitation amongst the CDs slightly, including myself. Just talking on behalf of the CDs at board, just to say that there is agitation that this is not being worked on quickly enough, and so the EPUT team can't integrate fully into the EMIS and System 1 in the practices on behalf of the PCNs, and that is holding us back.
I'm not, Frida, but I'm happy to, unless Pam knows about it, look into it. If you drop me a note, I'll pick it up because I think we've had similar challenges in the Suffolk patch, although it's been with System 1 interface with NSCP.
Yeah.
Found a workaround.
Okay. Thanks, Richard.
Thanks. Pam, can we, it's the last comment then so we can move on?
Yeah, I wasn't going to mention EMIS, but it's the EPUT are working through it. There has been investment into that. I just think it's slower. I think there's acknowledgement that the system has to work for you, not just you, Frida, but it has to work for primary care so that those individuals can be tasked effectively and feel part of the team, and all of the risk stratifying of the patients that they're seeing and the clinical safety is there of working the system. So we're absolutely clear on that. Just one thing around housing, Patrick, and mental health. That I think there's quite a few streams around support for housing. So the Alliance has invested into mental health workers in supported living, and the housing stock that both Colchester Borough Council and Tendring District Council have to support those with enduring mental health that are living in those accommodations, renting or otherwise. And we now have a housing officer in the discharge hub at Colchester Hospital to support where people are struggling with housing. That's not adaptations, it's challenges around housing. So have they got a housing need that's not being met? So I think it's an area that we're working on quite broadly. I think adaptive living and specialist accommodation is another area that we probably need to do more work on. I think we've done the sort of can we adapt the house? Can we get people into housing? Can we support them in the housing? Can we support their mental health whilst they're in the housing? But there is obviously something about specific stock that the Alliance could look at.
Perfect. So I think all that's left now is me to thank you, Richard. I agree, it's a very detailed paper, and it was the ask of the board. And I think there's the only question I had has already been answered, which is around making sure there's some patient engagement through some of all of this and how we make sure that's effective. And so hopefully you got that on board, because that's the last question on this second to last slide as well, I think, isn't it?
Yeah,
Great.
happy to pick that up. Thank you.
Perfect, thank you. So Jane, sorry, we're running a bit behind. And also, by the way, I've noticed that some people have been sat in the same position for the last 1 hour and 10 minutes. So do feel free to turn your camera off, shuffle a bit, or just stand up or look away from the screen if nothing else. Jane, sorry.
Okay, yes, and please do that during this paper, which is effectively,
yeah, not while Jane's talking, please do.
Effectively a governance one. No, hopefully it won't take too long. So for people who read the paper, it explains that we're working in a financial year that's been split into 2 halves. When I wrote the paper, we were awaiting our the financial planning and the wider planning guidance and the allocations for the second half of the year. Those actually popped in last Thursday. So we are working through those as we speak. They look very similar to those that we received in the first half of the year, with a little bit more efficiency, as it highlights in the paper, but broadly the same. So so hopefully in terms of North East Essex, as we are, as I'll be reporting in the finance paper, we are on track to break even for the first half of the year, and I predict that looking at the allocations we've received, we should be fine for the second half of the year. However, the timing is not great, so we do need to do a little bit of governance if the governing body is agreeable to it, insofar as it's for the governing body to sign off our budgets. I'm proposing that we do the detailed work at the Finance and Performance Committee, which will take place at the end of October, so that we can achieve the submission deadlines, which have been slightly extended from the paper, but are mid-November. So if the governing body is happy to do that, I suggest that we let F&P do the detailed work on the budget, and I'll bring back a report to the next meeting, just so you can see the overall impact of it.
Thank you, Jane. Any questions? How are we going to safeguard against maverick behaviour at F&P?
Well, obviously, the F&P meet on a monthly basis, and we've got Jerry here today. We haven't got Martin, the chair, but they very used to looking at detailed papers on the financial position and the budget. But I don't know whether Jerry wants to comment. As I say, we will bring it back so that it's accountable in public to the next meeting.
Jerry?
You're very welcome to come, Hassan. Your presence to be valued is one way. But don't worry, I'll keep Martin Hanlon in check, is the other suggestion I would have. Apart from that, I think it should be fine. That's the best I can think of saying, Hassan.
I was going to say famous last words, but you know, I think that'd be unfair. So no, I have full faith in you. I think I guess what I was getting was, if there's some deviation from what is the expected norm, then hopefully yourself or Martin can pick that up and flag that with myself, if you like, and if timing is appropriate, and if need be, we can always convene an extraordinary meeting should there be some need to do so. It's just really around a caveat, so to protect you all in essence. Okay. Questions from anyone else? No. So is everyone happy with the recommendation to delegate down H2? I've never heard it called H2 before. I don't know if that's new accounting terminology, but second half. But yes, everyone's happy to delegate to F&P, subject to if there's some concerns they'll be raised through Jerry and Martin via myself initially. Okay, perfect. Thank you. And I've just been advised that we've not got any questions from the public, which is a bit disappointing, I have to say. I'm looking forward to being able to do this in public, so people get the opportunity to ask questions. But we'll now move on to procurement update from yourself, Pam.
Sorry, take myself off mute. Yeah, so this is the standard update, and I'll take the paper as read so that we can make a little bit of time up. You can see that the couple of procurements that are underway at the moment are relatively small value, and the pipeline continues to be relatively extensive. But I'm happy to take any questions.
Okay. Questions from anyone? Comments? Concerns? This pipeline. Oh, sorry, Max.
Thank you. Can I just ask about needs? Looking at it, there's sort of, I get the sort of impression that I'm not quite sure. It looks like we're extending. We have extended the contract, yeah, and we're thinking about extending it further. Is that what it's saying?
As I said at the last board, the diabetes service expressed an interest to be part of the NICS contract.
Right.
And we put out to the market that we would want diabetes to be part of the NICS contract for the future. The way that we're working through that with them at the moment is we're working through with the alliance partners to get the right arrangement that suits both Suffolk Federation, who expressed that interest, and the rest of the partners and primary care. So it doesn't necessarily mean that there will be a further procurement out of the end of those conversations, because obviously they've already expressed an interest in being part of the NICS arrangement, and we put that to the market, as I said. But we have to ensure that what we do follows procurement laws and is the right thing for the population and the alliance. So that is underway. I will be able to hopefully give a further update at the next board around that provision. But it's fair to say that, and Frida, I'm sure, will contribute here around the success of that service to date, and we continue to have upper decile performance in the monitoring of our diabetes patients in North East Essex. That would therefore indicate that the model is supporting primary care well to support its patients on diabetic registers, as well as those that obviously have admissions to hospital or require higher intervention of monitoring devices, etc., etc. So that is, it's not quite as straightforward as you would imagine, Max. It's quite complex when you're working through an alliance with 7 substantive membership groups, as well as 2 representative groups of sort of the local voluntary sector communities as members of that arrangement. It takes slightly longer to make a decision, but we have a clear approach to resolve that.
Okay, thank you.
Thank you, Pam.
That's legal, just to be absolutely clear.
Jerry.
Yeah, my question relates a bit to the discussions we had in the private section, where there was only one bidder for a particular contract. Yep. I wonder whether there are any plans, and I think it's been mentioned quite a few times before, where we've only had one bidder for a big process, where we've paid for an expensive firm of consultants like Attain to do an awful lot of work. Are there any plans under the new legislation to streamline things, particularly when you get that scenario, as it must be possible to save money in that area, because once you've only got one candidate for a particular set of services, and it is the incumbent as well, surely you could come up with a system where you evaluate their performance, and if it's acceptable, you don't go through a full procurement process using an expensive consultant.
So Attain are not commissioned on a case-by-case basis. They offer us a service as if they're employees to us. So we contract to them for all of our procurements. So there isn't a cost per procurement, essentially, just to assure you of that way of working. So I think what previous conversations today have demonstrated is that actually, even if there is only one bidder, we absolutely have to assure ourselves of the capability, the value that provider will offer for the future, because whilst it may be the incumbent, as per conversations we've had previously, the specification may be very different. So it is really important that we do all of those tests still, and we're obliged to do those tests. Irrespective of whether there's 1 or 10, if you cease to procurement process, you'd effectively be doing a direct award, and that our governance is not going to allow us to do that beyond a small value contract. So that diligence is still required, but it's less about the cost of attain and more about the cost of failure of the contracts, I would suggest.
Happy with that, Jerry?
Not fabulously, but basically you're saying, Pam, there's not going to be any change. We're still going to carry on with the same process. I mean, if you've got a set of staff who are monitoring a supplier over a period of time, then surely you can make an assessment without using attain, is my main point. But anyway, I won't prolong it any further.
We don't use attain to make the assessment of the quality of the provider. Attain just manage the market advertising and the pure procurement process. It is still absolutely all of our subject matter experts that do the evaluation of all of our providers. So it's quality staff, our financial staff, our primary care staff that monitor the interface. There's huge resources around procurement that is nothing to do with the attain workforce. That's the diligence process, and we wouldn't step away from that.
Yeah. I mean, I know we've asked a question in the past around actually the overall cost, but it's been difficult to tease out certain elements of what we get out of it. But I mean, that might be a useful exercise. I guess part of me thinks in 6 months there will be no CCG, so it's the Alliance and the ICS's problem how they procure services anyway. But it might be useful for us to at least know what sort of expense that has incurred as part of any procurement exercise. To ensure it's value for money.
So it's a division of day rate. Well, not day rate, but
yeah, we have to do it now. It's not a mental arithmetic challenge, but you know, at some point.
But yeah, we can do that. But previously, we employed substantive procurement staff, and actually, it was and you know, Jane will be aware the amount of cost that it requires to cover staff, as well as sickness, maternity leave, pensions, training, constant training, is also expensive.
Okay, Frida.
Yeah, I just very quickly wanted to share the diabetes PCN data on the needs. I mean, I just was looking for the slide, and North East Essex CCG was ranked first based on 433 PCNs activity using Diabetes Complete. And then I've got the rankings of all the PCNs in the area, if you want me to send that round.
No, we don't want to hear about your practice again, Frida.
No,
it's all of us.
It's all PCNs. It's all PCNs. So I think that's incredibly good, actually. Yeah. And the first, and actually Hassan's one came up quite high, actually, is PCN. But anyway, I send that round. But it's a good news, you know, that we've done so well.
Very good news. Very good news.
You don't have to act so surprised. I mean, so, oh, Hassan's up there as well, right? Thank you. So if there's no more questions, I think we'll move on. Thank you for the update, Pam. It'd be useful if we can work out that expense, because actually, if we've never quantified it before, I think we should quantify it somewhere in terms of the expense to us, even if it's for op exec to look at first or F&P. Great. So let's move on to integrated performance report. Now, Vicky, are you taking this for?
I am, yes.
Welcome.
Okay, so I'll take the paper as read, and just firstly to confirm that the paper and the individual provider performance was discussed in detail at the Finance and Performance Committee last week, who were assured that all necessary actions were being taken with the providers around improving performance. So I know Martin's not here today, but I would invite other members of F&P who might want to add any comments to that at the end of the report. So I'm not going to go through the report in detail. I would bring out some highlights and summary for you, just to say that the local CCG priorities remain those aligned with those national areas, around elective recovery, cancer restoration and urgent care. So in terms of elective care, I think Ed mentioned this in his report at the start of the meeting today. There's been good progress around recovery for elective areas, particularly around the 52-week waits and those 104-week waits. Although there is further work to be done, obviously, to meet that challenge by the end of March around the 104-week waits, and that will be done as a system. So there's already the mutual aid being put in place between ESNEFT and West Suffolk, because that will be a system-led target. I think it's also just worth pointing out that it's recognised that some areas and specialties will be a bigger challenge around meeting that 104-week target, particularly around oral surgery and the subspecialties. So just noting that for the board's awareness. In terms of cancer, the data suggesting that unfortunately we may not be recovering the 62-day target as quickly as we would like. We did have a trajectory in place to recover that performance stand by the end of September. It's possible that might not be met now. So if that is the case, then there'll have to be a revised trajectory, and that will be in line with the new planning guidance that's been issued last week as well. Just for awareness, the main issues around cancer remains the incessant increasing demand in 2-week wait referrals. So that's having significant pressure on the service. So anecdotally, we've heard that ESNEFT has reported a 30% increase in 2-week waits on this period on previous years, which does put pressure on the service. That hasn't been validated, but it does reflect back in the conversations that there have been more referrals, which in one way is a good thing, because I think we know that there's been a catch up around people that didn't get referred last year. So we're probably seeing some of those patients now starting to come through on the 2-week wait pathway. Also just to note then, the RTT position may be impacted by that cancer and performance, as well as the capacity will have to be reprioritised for cancer services if they need to do that. Just in summary then, for urgent care, I think we all recognise the challenges that the urgent care system has been facing, and there's been increasing demand for both A&E attendances and ambulance conveyances. So the team have been focusing in the last few months, as we'll say, rather than just weeks, around winter planning to ensure we've got some robust winter plans in place that will support those pressures as they're likely to increase over the following months. Just to say that it's kind of that will happen now in tandem with the requirements of the planning guidance for there to be an urgent and emergency care action plan. So the areas that are focused within that are the areas we're already looking at. So that's just quite a high level summary of our kind of key priority areas. So I'll pause there, but I'm happy to take any questions.
Thanks, Vicky. You got any questions? Okay, I mean, I think for me, what people are thinking, so I mean, seeing the figures, this has progressed over years, actually, hasn't it, in terms of this report and how we get it, and it's useful to see change. And I guess the question for me is how do we get in a report the reassurance that there's a plan to recover? Because that's kind of the question we'll all ask, isn't it? Well, how are you going to recover that figure, that figure, that figure? So what level of reassurance do you have, if you do we have, that we can recover some of these figures, particularly cancer rather than necessarily elective care? So
there are numerous forums where these conversations are happening around recovery areas, and then different members of this the board might be part of those groups as well. So particularly, I think Richard might be part of the cancer board. Sits in place that has a lot of these detailed conversations around recovery for cancer areas. So there's a lot of scrutiny that comes from region and NHS England on those areas as well. So there are, to give us a level of assurance, it's not just the CCG that's managing it, it has a high level of scrutiny now, but I think Richard's got his hand up, so he might want to come in with further points.
Hey, by the bell, Richard.
So just briefly on cancer, to add to what Vicky said. So we have an ICS cancer board, and we also have an ICS operational group that's got both the clinical leads from the CCG and our acute hospitals, and it's also got the management leads, and it has also got the Cancer Alliance, which is the regional interface. And actually it's working quite well as a kind of a tripartite of clinical leads, operational leads, CCG leads, with our alliance partners on both operational and transformation items. So for instance, the biggest challenge we had arguably more recently was breast cancer performance within ESNEFT, and we've held a number of meetings and a workshop indeed to look at that challenge, and invited a number of external speakers to challenge our own thinking in terms of what we're doing. And that has led some proposals that were about developing a revised model around that area as an example. And we're going to be doing that with dermatology, which is another challenge we've got within the council, mostly in the West, it's fair to say, but I think ESNEFT would also benefit from some of that. So we're trying not the kind of just the usual, we want a rapid recovery plan. It's about how can we challenge our thinking, bring external speakers in to challenge what we're doing and think about other ways to meet those challenges.
Okay, thanks, Richard. Does anyone else come up with something? Questions?
Can I just ask?
Oh, I didn't see a hand go up, Max. Sorry. Yeah, Max.
Oh, yeah, sorry. No, I didn't have to put it up. Can I just ask on page 3 of the report? It's got the 18 weeks referral to treatment, and then it's got for each speciality where we are with all those. And then in the last column, it's saying for what it was for July. Why the different colours? I don't understand. It's almost like a RAG rating, but doesn't seem to tally with how long the waits are. I mean, I can see that we've got a gradual improvement, haven't we, and quite a range between specialties.
Okay, Vicky, can you answer that one?
Yeah, I believe the RAG rating is meant to show whether it's a deteriorating position or improving position, or if it stayed the same. So that's the basis of that last column to indicate against the previous month.
Okay.
Oh, that works. Okay.
Oh, I see. Yeah. Okay. Right. Yeah.
Okay.
Yeah. Thank you.
Mark.
Thanks, Hassan. Sorry, one small question just from a personal example, and wanted to ask, we have to obviously focus on these deadlines and absolutely have to continue to work to improve alongside them. However, I have a friend who has undergone treatment but has not had the results back after sort of having an operation, and I just wonder that she may have been seen in the right time to begin with, but then the follow-up and the quality of that, and never want to see sort of perverse incentives that we follow particular timings, but then don't follow up with the quality. So I know that this is just one example, and you are all working extremely hard and catching up with work since COVID, but I just wanted to put that small example forward. Thank you.
Thanks, Mark. Vicky, so I guess that's a bigger question, isn't it, around hitting a target, and then basically if it's not a measured target, you're kind of invisible. But we've asked this before, haven't we? Have we got some reassurance that that's not happening?
So I'm happy to go back and ask a specific question about those areas, but we have had assurance before that, but they have put in place the qualitative checks as well about making sure they do follow up patients and they keep checking in with them. So absolutely, it's for them. It shouldn't be about just hitting a target, and when there's an invisible target as such, that gets ignored. So I'm happy to raise that with the trust to make sure that's not becoming an issue. It hasn't been raised before, but I'm happy to make sure it's not becoming an issue.
And a similar question was around if people decline their first appointment, there's some not counted as well. So you know, I'm sure none of that's happening, but it's just really keeping an eye on the data, isn't it?
Yeah, absolutely. If there's issues, they should be managing the referrals in line with their access policy, which is published on their website. So you should be able to see how and when patients should be discharged. There are special exceptions as well for vulnerable patients, so that shouldn't happen at first appointment. But if there's any examples of where that's not happening properly, again, happy to raise that with the trust.
Speaking, Max.
Yeah, just also in the performance pack, the third page. Actually, now going on to the fourth page. So you've got this summary of how each of those organisations are doing, aren't they? Isn't it? I'm just a little bit mystified. Why you've got EPUT, the IAP service, the CQ standing with C rating of outstanding, but I thought it wasn't EPUT. I thought it was NF. It's NELFT, isn't it?
The IAP service, sorry, did you say, Max?
Yeah.
IAP is run by EPUT. That was taken over by EPUT at the beginning of April. Before that, it was HPFT.
It's Hearts and Parts.
Yeah. It was Hertfordshire Partnership Foundation Trust before EPUT, so pre-April.
Okay, sorry. So it is EPUT now, yeah. Of course it is, yeah.
Sorry. NELFT is our CAMS provider. NELFT is our CAMS provider.
That's right. Sorry, yeah. I got confused. Yeah, sorry about that.
Okay. Right, okay. So overall, I guess I think it's hard when you've got so many figures thrown at you. It's hard to know whether we're improving static or not. What's your gut feel, Vicky, Richard?
So I think in terms of elective recovery, I think we're in a good position, as Ed said at the start, in terms of the system. We were the only ones who had met that accelerator target by the end of July, so that's showing good progress. I think the issue we have is that we're working as a wider system. So for elective recovery, I think SNF is doing quite well. We're quite confident about the areas, but obviously there's some challenges for West Suffolk because of their loss of an elective theatre, so that potentially impacts on that. But I think my gut feeling is they're doing well, and it's whether that is making sure that can be sustained. So in terms of the pressures of going into winter, and I think that's a balance that, and every system will face that challenge of the conflicting pressures of maintaining elective recovery whilst managing those urgent care pressures. So that would be my feel around elective recovery.
Okay. And are we as best prepared as we can be, Richard?
Is that a general comment, or is that specific on elective?
Life, but specific on electives.
Oh, that's a difficult one. I think we're as well as prepared as we can be, which is probably a politician's answer. I think it's just, let's be honest, on a day-to-day basis, it's hugely challenging for all concerned. As Vicky just said at the end, we're trying to balance ongoing urgent emergency care pressures with maintaining our elective activity, and that's challenging in the best of times, let alone when you add on the additional requirements of COVID. But looking across into other areas of the region, I think, as Vicky said, we are doing relatively well. And the fact that we're the only of the accelerators to have achieved our target, I think, says something around the strength of what we've currently got operating. And one of the positives I think that has come out of this is the further work between the acute trusts. So this has really pushed the two trusts towards supporting one another in a way that arguably we didn't necessarily have before. So that has acted a bit of a catalyst, and I think there's far more we can do on that, particularly around musculoskeletal and eye care, where we've now got ICS-wide boards for both those areas, clinical leads in place who are now starting to meet, talk about how they can mutually support one another in both immediate challenges and longer term pieces. Again, I'm not hearing that uniformly elsewhere.
Okay. Thank you. I think it's as good as we can ask. It's just, I suppose I just appreciate the system's all very, I won't use the word fragile, but actually we're on the road to recovery, it seems, and with winter coming, with the booster program, hopefully we can stay on track. But I think we probably are a little bit fragile, and all the staff, we're all a bit tired, and so we just need to be mindful of that, don't we? That if we hit a stumbling block, be it a flu outbreak, for example, it might make a difference. It's just planning for that. There's no other questions. I don't think there is. So we were asked to note that report. Thank you, Vicky, for stepping in. So audit committee report, Jerry.
Yeah, just happy to take questions really, Hassan. We've had the AGM where Jane gave a very comprehensive presentation on some of the aspects of the audit committee. So if anybody wants to ask anything, happy to try and answer.
Anyone forthcoming? I'll wait a little bit longer. No, okay, all right, perfect. Thank you, Jerry. Where are we up to next? Alliance Committee overview. Is that you, Pat?
There is the audit committee annual report, which Jane did.
Oh, sorry, did I miss one?
It's a separate item.
Sorry, I missed one.
So it is a separate item, but effectively it's for information. It's just a summary of what we've been doing in the audit committee over the years to update the governing body. So again, just happy to take any questions.
Okay. Any questions on the report that I missed? No. And I'm 08 we're asked to note that, aren't we? Yep. Okay. Right, now let's move on then. Sorry. I'm trying to flick through without overrunning it. Alliance overview report. Wow.
So as per my earlier comments, the Alliance Committee is a delegated subcommittee of this board, oversees the integrated decisions around the Alliance as well as broader commissioning for North East Essex. So this report I'll take as read, but it gives you a summary of the activities of the Alliance and its construction, its governance and its programme management approach. We've already heard today around the neighbourhoods, and I'm quite happy for us to give an update on each area of the Alliance programme at subsequent boards, if that would help to give context around the full workings of the Alliance. Then within the committee, the paper, you can see that the subjects and papers that we've had brought to the committee for agreement. I'll offer my words of wisdom in this section, and then I will turn to Councillor Mark Corey as the chair of this committee to offer his assurance to the board that we're functioning as per our delegation. So I think what you can start to see from this report is that we are covering expansive range of subjects, and we have good attendance from both officers and elected GP representation, which is invaluable in that setting, as well as our PCN directors. So this gives a broad window onto the future commissioning, as well as the current sort of governance that we've got arranged with the CCG board. So I'm happy to take any questions on those items that have gone through it. I think any large items would have then obviously come through here where necessary, but these have not these have stood within threshold of the delegation of that committee. So happy to take any questions.
Thanks, Pam. Mark, did you want to add anything before you run?
Yeah, thank you. Not much more really. The paper does outline the key decision-making elements that we've had over the last two committees. I can give that assurance, as Pam has said, that it is functioning well. There are always ways in which we can improve, but it's good to see them progress on to this board, and for me to have full context in that, and other players and partners who are not on this board who have contributed through the Alliance approach. So it just continues to ensure the Alliance approach can work, and officially to sign off and agree funds for those projects, some of which have already come, as Pam alluded to earlier in today's agenda.
Mark, thank you, Pam. So has anyone got any questions about the content or content of the report? In which case we will note it, and we'll move on to primary care commissioning.
Yeah, so
It's you again, isn't it, Pam?
Yeah, sorry, it's me again, without Mark this time. This is a summary of the Primary Care Commissioning Committee. Again, another subcommittee of this board oversees the management of the primary care contracts with NHS England as a party to that board, as we have delegated commissioning rights for primary care locally. And also has our out of area GP from West Suffolk, Dr. Flathers, who supports us in the decision making with an objective opinion around any decisions there. I'll take the paper as read. Clearly there's been a lot of activity happening, a lot of quality work, also a lot of training updates around suicide prevention, which obviously was of interest to this board as well as the ICS board. I'm quite happy to take any questions of the content of the paper.
Have we got any questions? Can I I'll ask one, just to pick on one thing, just the reds, because reds obviously draw your attention, don't they? So when you pick reds, I think, oh, and it's around the safeguarding training.
Yep.
So, I mean, my understanding is actually that can now be done, it's done by teams. And so the old excuse of getting to Aspen House, whatever, from be it Tendring or be it from South Colchester doesn't really stand anymore. So how can we justify such a gap in safeguard? Is it just renewal dates have fallen over, so we're just looking at it at that particular time, and everyone next month it'll all be back to normal? Because I mean, I thought that's a significant.
Yeah, so it's something that we're working with the safeguarding team on it around our ledger of keeping them updated. But obviously safeguarding is runs into and is supported through GPPC's records as well, so for the online training record, and there's been a change in the provider of that, I think. So I think we've just got to get some data cleansing going on that as well, to make sure that it's fully up to date.
Okay, it's not to pick on it, but it's just, you know, that it,
it needs it absolutely needs to be up to date, and we obviously offer full support from Lisa's team around safeguarding, the safeguarding training. We have nurses employed fully to do that training as well, so there is no barrier to it. I think obviously a lot of the pushback that we've had recently is about demands on people's time, so we're supporting people to make sure that they understand the necessity of doing that.
Perfect. I mean, we, you know, as a CCG, you know, we have looked at this once a month educational afternoon, and so the whole intention of that educational afternoon is if there's not a event, you're able to get your training up to date, and so it's just slightly concerning if that's not happening.
No, we're working with the safeguarding team to get it resolved.
Max?
Yeah, I think thank you, Chair. I think it's a good report actually, because it's a nice, but you know, fairly concise summary of primary care targets. I think one other area I would pick out in terms of red is you know, we've discussed it quite a lot at the clinical review group, is our prescribing of benzodiazepines and gabapentinoids and things like that, you know, and how we're a bit of an outlier really, or not a bit of an outlier, we're a big outlier in North East Essex compared to other areas in the country. And the other I just got a slight question mark about is the diabetes, which has got red rag rating on a couple of items there, which doesn't quite tally with what we just said earlier on. And I don't know whether that's we're setting ourselves a very high target and we're not meeting it, or you know, how are we doing compared to on those two compared to other areas?
So we're still doing better than other areas, which is why in the PCN rating we're high. We still have some issues around. This is the part that's delegated solely to practices to do the reviews. So where there isn't embedded staff from Suffolk Fed, there has been a challenge around those are the same individuals doing vaccination. It's been more of a challenge this year. Vicky and her team have been working with the contract holders, obviously Suffolk Fed, to try and work through how we get the best rate of delivery on there. But it's very often workforce related. It's obviously you know, all the workforce have been deployed in different ways through the pandemic, but we're working with Suffolk Fed to see if actually they just embed some more staff into those practices where we're struggling. So we know the reason for it.
Again, a bit of a COVID thing, isn't it? You know, it's not been that great recently because of COVID. Yeah. Okay.
Okay. Thanks, Max. Thanks, Pam. Any other questions? Perfect. In which case, again, as Max said, it's a very useful report. Thank you. I think we're getting really good with our reports, actually. There. Just a shame.
Just sort of winding up.
Yeah, that's the way it takes so many years to get to the report that you need, and then so hopefully it'll be carried forward in our alliance in terms of utilising some of these reports, I hope.
So Hassan, just to assure you, I think one thing that we do know is that we're obliged to have a primary care commissioning committee for the future. And we won't after 76 minutes.
That's how long it takes, Ed. You know, you can't rush excellence.
I wouldn't say he's happy, you know, he doesn't.
So we've spent a lot of time in the last couple of years, particularly trying to get a primary care report that the LMC likes and practices feel is useful and adds some value in this meeting as well. I mean, it identifies things like Max has said, actually, you know, are we an outlier on benzodiazepines? Actually, that report is now being recast based on deprivation and all the things that Dr. Mirza, God rest his soul, used to say to us when we used to visit that actually, you know, it's very difficult to bring down the prescribing in those areas to a normalised level. Actually, the prescribing guidance is now adjusting based on those wider determinants of health. So we're not as far an outlier, or we won't be in the future, as the report suggests at the moment. But I think, you know, I'll happily take any further comments on the report, because I do hope that this report will continue post the CCG into the ICS Primary Care Commissioning Committee. So any added commentary is valuable for the future. It won't be lost.
No, thank you, Pam, and thank you for the report, which we noted. So, Jane, you're going to talk to us about your crack problem.
Yes, thank you, Chair. So short report on the COVID-19 Resource Approval Committee, shortened to the CRAC Committee. We looked at the detail of what's approved through this committee that works across the 3 CCGs in Suffolk and North East Essex at the Finance Committee, but this is just a summary for the board. We've met as a committee twice since we last reported to the board, and the decisions made there across the 3 CCGs are shown in the appendix. As you'll see from that, if you've been following this, we have the amount of committees and the amount of decisions being made have slowed down significantly, with the committee really focusing on things around the vaccination programme and making sure that we're doing prior approvals of things such as hospital discharge programme, which are naturally flowing through the CCGs. The paper also suggests and asks for the governing body's permission to extend the committee until the 31st of March, with that kind of proviso that we only meet as and when is required, as you can see by the amount of decisions in there. But this is to line up with the extension of the emergency financial arrangements till the end of the year. And I think as we're going into winter, it's probably wise to just have this committee ready for anything that it's needed for over that period.
Thank you, Jane. So any questions about the content of the report? I just have a proposal. Well, no, it's not a proposal, but as you know, the way that the meetings are sometimes diaried, it's sometimes hard for me to get to them. I think the last couple have been on a Monday, I'm not sure, but it's just whether if we knew that we're going to have maybe 2 or 3, if we could put them in a day that works for everyone, and then if they don't need to happen, they can get cancelled. I don't know whether that's practical, but maybe that's just me being selfish, but for what works for me. But just conscious of the fact that I can't always make them. That's all.
Okay, yeah, we do tend to organise them as and when, but I'll have a chat with Joe about whether there's anything we can do that makes it easier for you, Hassan.
Or at least have the occasional one on a day that I can get to, at least. Okay. Any other questions, comments? Okay, so we're asked to note the contents. I'll back them up anyway, and everyone's happy with the extension till March. Okie dokie. APC. Pam?
Yeah, so I will take this paper as read. If anybody can pronounce all of the drugs in here, they get a treat, because it's full of very clinical wording. I shall turn to Prashant, who's a member of the APC, just to give his assurance around the function of the committee in a moment. But this is a pan-ICS pharmaceutical committee that I think this demonstrates how we're working to one formulary across all providers, and from a commissioning perspective, these are agreements and the minutes of the meetings that have been held since we last met, and any sort of recommendations out to referrers or shared care individuals have been communicated out to both primary care and secondary care. But it's I'd take it as read. I'm probably not the best person to answer all the questions, but if anybody's got any, then Prashant will answer from a clinical perspective. Anything to add, Prashant?
No, I think you touched on most of the stuff, but I think from the main discussions were around the patient safety issues, as always, the valproate in pregnancy, the use of antipsychotics in dementia. And I think we had a bit of a discussion about where we were with warfarin many years ago. The dementia team saying that please make sure that you descale the treatment for NOACs, because NOACs with folds and bleeds and all that. So yeah, mostly around patient safety and how we're going to function. We also discussed how blood samples will be sort of delivered, because at the time when we had the meeting, we had this shortage of blood tubes and all that. But apart from that, I think there's not a lot to report, unless and until if somebody wants a specific question, I'll try and answer that.
Thank you both. I must say, I think pathway-wise, it'd be better if this flowed through the Alliance Committee rather than necessarily getting this level of detail at board, but happy to be challenged if people wanted it, but I thought it makes more sense for it to come to Alliance Committee and then be ticked off there, but for what it's worth. But
I'm happy to do it that way. We always used to take medicines to Transformation and Delivery Committee, again a subcommittee of the board, but it was felt that because it was ICSY that this was probably the most appropriate committee, but we can discuss that, Hassan, afterwards.
Yeah, I think it's just in terms of the right skill mix for scrutiny. Yeah. As you said, a lot of this is clinical, and I know there's some of us here, but actually that level of clinical challenge or concern should be at that level where you've got more clinicians present, I think, personally. But we're asked to note the contents of the report, so if anyone's happy.
Thank you. Okay. Thank you.
Board assurance framework. Amanda, you've been very patient.
Thank you very much, Chair. So here we have our updated board assurance framework, and since our last governing body, we have actually added 2 new risks this time. One on system resilience, which reflects the pressures that we are experiencing across system with regards to urgent and emergency care sector. And the other new risk is regarding our maternity, and with regards to SNF, they have been placed as
I'm not sure if you're fast forwarding and doing a bit of pausing.
From the risk register, and indeed, I may have. Sorry, can you hear me? Okay.
I think we lost you through most of that, Amanda. I don't know if it's just me, but
I'm going to turn my camera off, Chair, which might help with the connectivity. Okay. Is that a little bit better?
Yep.
Yep. Shall I repeat what I've just said then, Hassan?
Just start with the two additionals. I think I lost you at that point.
Okay, so 2 additional. One was regarding system resilience, which basically reflects the increasing pressures we are experiencing across our system regarding emergency and urgent care. And the other new risk is regarding maternity services across SNF. With regards to SNF, they are now placed on the maternity support programme. And I may invite Lisa Nobes to update a bit more on that. But before I do, I just wanted to update on another risk, which is regarding our white paper. And I think it's fair to say, as a clinical commissioning group, we are managing that as best we can. Indeed, we held a staff briefing yesterday and around 240 staff attended. Myself and Ed, along with our trade unions, updated the staff with regards to what the HR framework means to them and some of the next steps as we move our transition. We also updated our staff in terms of some of the imminent recruitment that's happening with regards to our ICB with effect from the beginning of April, and we know that we have appointed a designate chair, Will Pope, and we are now working towards appointing a permanent chief executive at the beginning of November, and then post that we are looking to recruit other key roles such as non-executive directors, and there is likely to be an advert in the coming weeks, and we are also progressing our director recruitment with the view that some of those key posts will be confirmed by the end of December. With regards to other key risks, we continue to meet as a risk forum where each directorate is represented, and the purpose of our risk forum is to really keep a watching eye on any potential risks that could actually bubble its way up to joining our GBAF going forward. But I think we do keep a good eye and manage those within our directorates without becoming an issue for our governing body. I'm going to pause there and invite any director comments to add to any of the risks that they are managing at the moment, Chair, if that's okay.
Yeah, that's fine. Any questions, comments? Lisa, oh sorry, Lisa, you're going to come in.
Yeah, no, thank you. Happy to give an update on the maternity programme. You'll know that this risk was added following intelligence from a number of reviews that ESNEFT had on both their sites, Ipswich and Colchester, into maternity services. I feel that they are on an improvement journey, but they have made some substantial improvements. Really, they have appointed their director of midwifery, who started beginning of September. So she's just sort of scoping out and getting to grips with the challenges that she faces in the midwifery workforce, and I think that's probably one of their biggest challenges, the workforce numbers, which has unfortunately delayed the continuity of carer rollout that we've seen across Ipswich and East Suffolk and North East Essex, just because the numbers of midwives that you need to operate a continuity of carer model are higher, and particularly in areas of deprivation you need a much smaller caseload per midwife than you can in other areas. They have an Every Birth Every Day programme which meets monthly, which stakeholders, including myself, NHSEI and the CQC, are invited to, and that focuses on workforce safety culture, governance and OD. And they have an organisational development lead that is working alongside them, that's doing some great work and is really generating a buzz and bringing a real energy to the OD programme. As Amanda said, they are on the maternity support programme, and they had a visit recently from our National Chief Midwife, Jackie Dunkley-Bent, and Sasha Barron-Wells, who will be supporting them themselves on the maternity support programme. So it is a concern. I mean, nationally, maternity services are a concern because the workforce issues in obstetrics and in midwifery are a national issue. But I do think that they are now delivering their plan, and we are seeing some improvement. Thank you.
Thank you. So that's reassuring. Has anyone else got questions, comments? Amanda, you said you're going to pause there. Does that mean you've got more to say? Really not.
No, Hassan, that's fine.
Okay, all right. Fine. Well, thank you then. In that case, we're asked to note the content.
Can I just ask sorry, I just want to have a very quick overview of the winter planning for ESNEFT in terms. Just have we got any information on, because the winter looks like it's going to be pretty bad, and that has a obvious impact on us in community care. And I just wanted to know as it's October board, what the plan is in terms of winter capacity.
Is that more? That probably would have been a question we could have asked at the performance report time, Frida or Richard, rather than for Amanda.
It's just triggered this report. Lisa just triggered that thought in my head, but I can hang on. It's not a problem. I just wanted to know.
So Richard can do a bit of well. Just wait. We'll take it up in AOB, shall we? Just to keep it neat. So any questions about that paper? No. Okay. Remind me at the end, Frida. Forget. Amanda, next one's yours as well. Is it the staff survey outcomes? Are you having connection problems still, Amanda?
Thank you, Chair. I will keep my camera off to aid the Wi-Fi issues. So here we have an updated report on the work that we continue to take as a CCG following last year's staff survey. And as we can see in section 2, we have listed all of the actions that we committed to several months ago. And we can also see in the right-hand column the progress as at the beginning of October following the last update to our governing body. This year's staff survey, the 21 staff survey, was actually launched across all 3 CCGs yesterday, and we may get an interim report towards December, of which we will then bring back to governing body. But I think, we are addressing and implementing the actions that we committed to, but very happy to take any questions, Chair.
Okay, thanks, Amanda. I guess with all of these, it's proof is in the pudding, isn't it? So we've got some actions that we've completed. So it's about the feedback that we then get from the staff around whether that's addressed some of the issues. Has anyone got questions about it? Did you want to comment, Pam, as Koo?
Yeah, I mean, I think it's a difficult time to assess your staff. It's been a challenging way of working over the last year, 18 months for many staff, feeling less connected with their line management, obviously experiencing different stresses at home as well as in the workplace. I think it's fair to say, and commissioning often doesn't get the same level of focus, and for some reasons rightly so, but as clinical practicing staff, but certainly I think our workforce in the CCG have been working under extreme pressure through the pandemic, having to turn to do lots of different redeployments, working in different teams, and shown resilience during that time. I think it's fair to say that there's exhaustion in our teams as much as there's exhaustion in the workforce out there on the clinical front line. And we are seeing a level of attrition within our workforce because of the changes. You know, in the uncertain times, you always see the first flight of staff when you go through an organisational restructure. So I think we need to make sure that we're consistently thinking about the well-being of our staff within the CCG, in putting in support mechanisms as much as we are in other sectors of health as well. So, you know, we're trying to support all of our staff as much as possible, but it has been a challenge. So I'm not expecting the staff survey to be necessarily much different from last year. I would hope that some of the concerning areas have been addressed by some of the interventions we've put in. But it has been a difficult year for the staff.
Thanks for those reflections, Pam. Matt.
It's that, I mean, some of that difficulty around having to work remotely, do you think? Is there any, you know, are we sort of gradually planning to sort of get more staff back into an office environment? And so a bit more, because you get that sort of, you get a bit more camaraderie, don't you, being in an office, and that you don't get necessarily from working remotely. Just wondering, is there a gradual plan to do that?
Just hold that for a second, Lisa. What's your question? Is it linked or?
No. Do you want to finish that first?
So who wants to take that, Pam or Ed?
Yeah, so we've done full risk assessments depending on the changes of the regulations around working. Obviously, we still have all our COVID security within the office. People can book office space, meeting rooms, etc. And we're, you know, supporting the teams to work either in a matrix way and feel part of a team, as well as, you know, working across directorates to pull people together. There is obviously still concern around the rates of transmission within community and bringing large groups of people together indoors, and we're risk assessing that as required. But you know, we are gradually bringing people back as is safe.
Okay, Ed, did you want to?
Yeah, I mean, Aspen House is really well set up now in a safe way, and I think what we're trying to get to is a sort of blended model where people are working at home and working in the office and getting a bit of a balance. I think from the staff briefing yesterday, there seemed to be some very mixed messages about an expectation that people should be in the office or the expectation that they should be at home. So I think we've got a bit of work just to be clear on that. But my perspective is we need to strike a balance and have a blended model. I don't see any office environment will go back full time in the future. I think there will be a different way of working which we need to embrace.
And it's just a change, isn't it? And with all things, it's just, I think at the start there was probably a little bit more concern and anger. Anger is probably too strong a word, but concern, I guess, about that way of working. But I think as times move on, people have got a bit more accustomed to it. And I think I think you're quite right. There's got to be some sort of a blend of a mix between the two. Lisa, sorry.
It's just 2 points really. Firstly, the point around having to work differently, and it is really challenging to try and kind of keep in touch with all your staff. As my colleagues know, I have 150 of them, and it's really tricky because I used to spend my days across my 4 sites, and I would sort of touch base with most people across that time. But now my most junior staff, it's who would really give you, it's a bit like keeping in touch with your frontline staff, isn't it? They really tell you what it's like and what's happening. Whereas I think in meetings you see the same people over and over again, but I don't see my more junior staff. So we've tried to do different things. So I have a monthly nursing directorate team meeting, which everybody's invited to. I have drop-in sessions monthly for 2 hours, which people can drop in. It tends to be the same people, but anyway, it's still an opportunity for people. But it is tricky. It's tricky because people, the more junior staff, when they've got issues, and I've kind of, found out about them later on, and I said, why on earth didn't you tell me? Because I could have sorted this out for you earlier. They just have this perception everybody's so busy and they don't want to bother you. Whereas when they see you in an office, they don't mind just stopping you. Or so I think it is an ongoing, evolving thing that we're just going to have to find a way to try and do it in the best way we can. But sorry, my point that I really put my hand up about, which was about so. As we move forward with the staff survey and we've got the action plan, I wonder whether there is just a bit of a different way of looking at it. So I was on a compassionate leadership course with the King's Funds the other day, and it was really interesting about the sort of the Maslow hierarchy of staff needs in the workplace, and it's called the ABC, and I've just got it if you bear with me. It's autonomy, belonging and contribution, and actually everybody needs to feel they've got control over their work life and to be able to act with their values and to be connected and cared for and feel valued, respected and supported, and to feel that they're delivering outcomes. And I wonder if once we've sorted out these nuts and bolts and bits and pieces in the action plan, whether we need to move forward thinking about it in a bit of a different way so that we're really addressing, because I think some of these things are the root causes, and some of the bits that come out on the staff survey are just the symptoms of not having that.
I think it's also about opportunity, isn't it? So if you're not having things like away days, team meetings, face to face, then things don't get solved and sorted, and so they can then progress and escalate and turn into something different. So it's a challenge, but as we've all said, it's not going to change anytime soon. So we need to try and find a way to embrace it, like we embrace better health. Max.
Is it too early to mention Christmas, Chairman?
Yes, it's too early.
I'm just wondering about sort of some socially distant sort of get-togethers would be helpful, or something social, something safe, but involving some get-togethers with staff would be good, I think. If that could happen, and I think we are coming into the festive season before you know it.
Maybe
I think the rest of the country is gradually opening up, isn't it? So
yeah. So maybe we need. I don't know whether we got some sort of social event planner. It's not me, boy. Huh? You want to be a social event planner? Are you planning it? Okay, I didn't realise that.
No. Sorry, did you ask me a question there? Sorry.
So no, I was just saying. Yes, great idea. I think we need to start thinking about team events or team events. Yeah, that's the word, isn't it? Yeah. And I mean, like people are putting comments in the chat, aren't they, around social events, but maybe we do need to think about that. Right, it's gone off on a tangent, this whole conversation, hasn't it? Right. Just remember, this is a public forum, so be careful what you say about Christmas parties next. Right. Anyhow, I'm going to move us on. So I think, you know, obviously the lesson is that we've had some actions around the concerns we raised around the staff survey, and those actions have been completed. So now we're going to be looking at second way round, and so hopefully it'll show some say focus. That people talking about food now. I'm starving. So hopefully we'll see some improvements, or at least if not some more constructive comments around how we can make it better for our staff. I agree. You know, we're all
indeed. Yeah.
And did you want to say anything else, Amanda, or before everyone's getting carried away with all this?
Not on that one. No. Okay. We can talk about health and wellbeing in a moment. That'll be good.
Perfect. Okay, so that's a good segue into health and wellbeing.
Perfect. Thank you very much, Chair. So at the last meeting, we heard that all of our 3 CCGs now have appointed health and wellbeing guardians. For North East Essex, that's Pam Dolany. And I think we previously committed to be providing the board with an update on all things health and wellbeing for our CCG at each meeting. So today's update is a paper that hopefully colleagues will have received, but it is really an update on the range of activities that we have actually had in place for quite a long time, to be fair. But I felt it was helpful to articulate under section 1, as we can see. In terms of some of the interventions, I thought it would be helpful to draw members' attention to a recently updated COVID risk assessment and wellbeing plan, and that was shared with all of our staff several weeks ago, and we invited staff to discuss and complete with their line manager and return to HR. As of yesterday, we'd had 299 return, which I think is very good, good response indeed. In terms of our health and wellbeing group, we have refreshed that, and the last meeting was 2 weeks ago. And in fact, all 3 CCG health and wellbeing guardians did attend. So hopefully they were able to see the range of activities and the support that we continue with our staff. In terms of your back matters, I just wanted to point that to our governing body's attention to say it has been very well received by our staff, and we've had lots of positive comments. So we would want to look at continuing that going forward. So all, in summary, Chair, I just wanted to provide this quick update to members just to reassure everybody that we're doing the best we can to maintain a health and wellbeing amongst our workforce. So I'll pause there, but happy to take any questions.
Thank you, Amanda. Have we got any questions? A bit disappointed I didn't know anything about a coastal walk, but that's fair. No one's invited me, so I don't know whether...
They don't want me to come, Hassan.
Well, exactly, yeah. I think it's a select group, isn't it? I didn't realise there was an elite within the CCG even, you know, it's just the coastal walking elite. Right. Anyhow, sorry, I distracted from your paper, didn't I? So thank you, Amanda, for that paper. Any questions around health and wellbeing? I mean, obviously it's got to be a priority, isn't it? So we've got to make sure, you know, for us, Pam's got the right resource to be able to do what she needs, or to support us in the best way. And I guess some of that probably will be informed from things like the staff survey.
Indeed, yeah.
Unless you're not in the clique and you don't get invited to the coastal walks. But right. So thank you, Amanda. We will note the contents of that report. So one AOB that came up, Frida wasn't paying attention earlier on in board. So who wants to answer the question about winter preparedness? Pam, can you?
Well, I think my friend and colleague Richard has done one and left that one to me. So, well, I am responsible for it locally, so that's absolutely fine. So where we are, as part of the alliance structure, we have SRG, System Resilience Group, chaired by Alison Power and deputy chaired by Vicky De Croo. Through this group, working with Paul Gabira's team in the incident management cell, we have been preparing our winter responses that have gone up in outline form to NHS England. They continue to evolve, but what I would say is that within North East, our system resilience group, again, you'll note a theme here, has our voluntary sector, district and borough partners very well engaged. So our response in North East has not only been about how do we evaluate the beds modelling and what gap does that leave us with, etc., but what can we do to keep people safe, warm, well, and avoid emissions. So again, through the resources we've been able to make available through the Alliance, we have supported the winter warmers approach that actually starts in Clacton and Jaywick this week. So giving out of winter packs, making sure that those that require additional fuel payments or have got faulty boilers, etc., are all being done now and supported by the voluntary sector. We have also worked very closely with our ambulance service, 111 service, and have implemented some different strategies to support admission avoidance. So the UTC at Clacton is also now, I learnt this morning, has got QR code based feedback for our paramedic teams. So when they don't manage to admit somebody through that route, they can give feedback as to how it could have been different, so that we can in real time now ensure that those pathways are really working for the most vulnerable in our society that do end up having an ambulance called out to them, etc. So yeah, there's been lots of planning around the bed modelling, the gaps. We obviously are experiencing the same crisis as the country around social care capacity, and we're working with Essex County Council and have just engaged Essex County Council have just engaged Newton Europe to do another evaluation around the hospital delays that we're experiencing at the moment to ensure that we have good flow through the hospital. There's been a significant piece of modelling done around RSV virus in children and the admissions, complicated respiratory conditions for children. For those that aren't familiar with RSV, it's a common cold virus, but it exerts its significant pressure on small children. And the modelling for flu. So we've built a model based on RSV, flu and COVID, so that we know what sort of planning we need to be doing now. I think it could always flip in one direction stronger than the others in those three disease presentations. We're seeing that we're tracking a bit higher on RSV in North East than we had already planned for, so children's admissions are higher. But we continue to build on the strength of the vaccination programme, the booster programme, as one of the things that will help us not have a disproportionate amount of admissions associated with COVID. I'm really pleased to report that whilst we do have difficulties within our social care market at the moment, we have got very, very low rates of admission from care homes associated with COVID, and Public Health were very complimentary this morning when they gave us an update around our outbreaks and our outbreak management, and they're really key pillars going into this winter that we've learned from last winter. So whole system approach, lots and lots of data modelling, drawing on the things that we've done well in the past around emission avoidance, and just continuing to try and support the ambulance service, particularly to take up those admission avoidance pathways.
Frida, do you want to come back on that?
Yeah, thanks ever so much, Pam. That's really good to know that it's covered, because obviously I think this winter's going to be pretty bad actually, and it's really good to know that you and Richard are planning around it and modelling it so well. I would just ask that perhaps at some point when things are, when you're able, when you're not so busy, you could get a letter out to all the CDs, PCN, TDs, just to let us know, just to let everyone know where the support is. I think that'll just make everyone feel really, going into the winter a bit more confident, perhaps.
Okay, thanks, Frida. That's something that you can maybe talk to
I'll
Frida.
take that as an action.
Perfect. In which case, I've not been advised of any other AOB. So if we overran a bit or underran, well, actually, 6 minutes early. Happy days. Next meeting is on the 30th of November. 3 months to go. I'll see you then. Thanks all. Lisa and Jane, can you just stick around for a minute, if that's okay?
Thank you.
Thank you. 30th of November, is that right?